Okay. We are recording, so we can go ahead and get started. Good morning, everybody, and welcome. I'm Caroline Palmer from the Minnesota Department of Health Safe Harbor Program, and I help to coordinate the Human Trafficking Task Force meetings along with our sexual violence prevention team, Mary Hopkins, Marissa Rudie, and Juliet Tyndall, as well as Injury and Violence Prevention Unit Supervisor Beatrice Manento. Thank you for joining us this morning. As you sign in, please be sure to introduce yourselves in the chat and let us know where you're from. The Minnesota Human Trafficking Task Force is an informal statewide network made up of people from around the state. The purpose of the task force is to address human trafficking in Minnesota through services, response, and prevention. This includes sex trafficking and sexual exploitation and labor trafficking and exploitation of individuals of all ages. We convene these quarterly meetings, which include presentations to keep us all informed, especially during this time when we cannot meet in person. While we cannot have an in-person discussion, we do encourage you to send chat questions throughout the presentation, and we will answer them and follow up. We have over 1,300 people from around the state and outside of Minnesota who are signed up on the task force list, the Sex and Labor Trafficking Prevention Network listserv called MinSTPN, and the Facebook page. Please sign up on these lists if you are not already on them to receive updates. Our meetings are recorded, and the recordings are made available on the Trafficking Task Force website about a week after each meeting, and we'll send an email announcing when it's available. Today we have several helpful updates and presentations. We will begin by welcoming Anna Negretti, who has joined the Minnesota Department of Human Services Child Welfare Response to Human Trafficking. She will provide a brief overview of her position. We are very appreciative of everything Anna has added to Safe Harbor so far. Next, we will hear from Emily Yang Lindeman from the MDH, who will provide a very important update on the new 988 Suicide and Crisis Lifeline. Then MDH Sexual Violence Prevention Director Mary Hopkins and I will describe 2 new resources and initiatives to train healthcare providers. Next, we will hear from Juliet Rudie, the Director of the Missing and Murdered Indigenous Relatives Office in the Minnesota Department of Public Safety. This office builds on the groundbreaking work of a task force that recommended setting up this office and coordinating the statewide response. And then I will wrap things up with a brief Safe Harbor update before we all go off onto our busy Mondays. Just a reminder, we are doing a new meeting evaluation, so please be sure to respond to the polling questions that come up at the end of the meeting. So thank you again for joining us, and I will turn things over to Anna.
Good morning, everyone. I just wanted to take a moment to introduce myself. My name is Anna Negretti. I'm new to the state of Minnesota's team. I started back in late April and hired on as the American Indian Human Trafficking Program Consultant. The core of my work is connecting with tribes and urban Indian communities to help the Indigenous people throughout the state address human trafficking in their community within the child welfare system. What that looks like right now for me is really just connecting with tribes in various different forms and formats, getting to learn who is doing the work right now, how human trafficking and exploitation is happening in their individual communities, and really trying to connect them with resources to address that best in their community. Introducing things like Not a Number in different areas where Native children are served, doing all kinds of things really to just really talk to, raise some awareness within the different communities and talk about how that is happening here and being of service to address and review things like policy, things that need to be changed there. So it's a brand new position and lots of learning ups and downs. What it looks like in one community is not what it looks like in another community. So I've been fortunate enough to build some connections and really just meet folks where they're at and address different trafficking and exploitation, how it appears in each individual community separately. So that's a little bit about my role. I'm happy to be here. I'll put my information in the chat if any of you would like to connect. I'd appreciate it. Thank you for your time.
Awesome. Thank you so much, Anna. And yes, thank you for putting your contact information in the chat. That's great. And please, everybody, reach out to Anna if you have any questions about her program and how she can help you out. Okay, I'm going to turn things over to Emily.
Perfect. Thank you. Good morning, everyone. Like Caroline said, I'm Emily. I am a suicide prevention coordinator at the Department of Health, and I work within our suicide prevention unit. Just give me a second to share my screen. And in my role here, I help coordinate kind of the statewide activities around the 988 Suicide and Crisis Lifeline. So I'm happy to share some information and background about the Lifeline and what we're doing here in Minnesota. So if you are familiar with the National Suicide Prevention Lifeline, back in July, that number had transitioned to what is now 988 Suicide and Crisis Lifeline. So it's not a new service, but it is a new dialing code, the new 3-digit dialing code. And what 988 does is that it builds upon the current infrastructure of the National Suicide Prevention Lifeline. So regardless of whether you call 1-800-273-8255 or you use the 3-digit dialing code 988, you're going to be routed to the same service. Just a little bit of background about the Lifeline. It started back in 2005 from the Substance Abuse and Mental Health Service Administration. And the Lifeline is actually a network of over 200 local crisis centers that are located all across the U.S. So each state has at least one Lifeline center that is part of this network. And only centers that are part of this network are the ones who are answering calls from the Lifeline. And the 988 Lifeline is meant to serve as a universal entry point so that no matter where you live in the country, you could dial this 3-digit number and be connected to a trained crisis specialist. So kind of the big takeaway here is that it is a national program. It's available in every state, but calls are answered locally at these local crisis centers. So there are 3 ways to connect to the Lifeline. One is you can call. Calls are routed based off of your area code. So calls with a Minnesota area code will be routed to a Minnesota Lifeline center. I do want to just acknowledge, I know this isn't perfect. There's a lot of people who live in Minnesota who don't have a Minnesota area code, and then there's a lot of folks who have a Minnesota area code that no longer live in the state. What we're waiting for is the FCC at the federal level to make a decision on whether or not they're going to allow the ability to route calls based off of someone's physical location instead of just their area code. But until we await that final decision, calls are going to continue being routed on your area code. So when you call the Lifeline, you're going to hear a few prompts. It's an automated message, and it'll ask that if you are a current service member or a veteran and want to be connected to the Veterans Crisis Line, you could press 1. If you press 2, you will be connected to this Spanish language crisis network center. And then the newest option is option 3, which is for LGBTQ plus youth and young adults under the age of 25. So if someone, excuse me, if someone presses 3, their call would be routed to a specialized center that would be able to answer their calls. So if you press 1, 2, or 3, your call gets routed outside of Minnesota. Our Lifeline centers currently don't participate as a specialized center to answer these calls. For 988, you do need to have some type of active phone service to make the call connection. So whether it's a prepaid wireless or some type of monthly subscription to a landline or wireless phone service, that does need to be active. All of our Lifeline centers do also have 24/7 access to third-party interpretation services if someone calls the line. The other option to connect to the Lifeline is through texting. So any mobile device that can send and receive texts um, can be used to connect there. Like phone calls, calls are routed based off of your area code. And right now, text is only available in English. And then there's chat. So if you go to 988lifeline.org, there is an option for a web browser-based chat feature. Um, there's a button that says chat now. You would click on it. Then you get a pre-survey that you fill out. It does ask for a name or an alias and then a zip code. And that's the zip code is what they use to know which states to route your chat to. And then again, um, chat right now is currently only available in English. All right, so I do want to just share a little bit of data around volumes to the Lifeline from Minnesota. So kind of that bar graph up at the top, that's from 2021, and just a breakdown of calls, chats, and texts from last year. Primarily in the past, we've just been promoting the 1-800-273-8255 number, which is why it makes up such a large part of the volume to the Lifeline. And we haven't been promoting chat as much, and text was under pilot last year, so there wasn't any public promotion of texting. But now that we've transitioned into 988, we are promoting all three modalities for connecting to the Lifeline. And so when we look at our data just from January to August of this year, we've seen a pretty steady increase in the number of calls. But the highest increases that we're seeing are in the number of chat and text that we are receiving. Especially after 988 went live in July, we really saw that, we really saw those numbers increase. And then just wanted to highlight that about 19% of our calls that we see to the Lifeline are individuals between the ages of 10 to 24. So here in Minnesota, we do have 4 Lifeline centers that participate as part of that Lifeline network. And so if you're calling from a Minnesota-based area code, your call is going to get routed to one of these 4 centers. And depending on where you live, one of these centers will serve as your primary Lifeline center. And then First Call for Help, based out of Grand Rapids, Minnesota, they also act as our in-state backup center. So in periods where there are high call volumes or um, increases or spikes in calls, any call that can't be answered by one of the other Lifeline centers would get routed to First Call. And that's just an attempt for us to answer as many calls in state as possible. If for some reason all of our call centers are at capacity, the Lifeline does operate national backup centers that would then take the overflow of calls. All 4 of our Lifeline centers operate 24/7, and they cover all 87 counties in the state with trained crisis specialists. And they are really focused on helping people who are experiencing thoughts of suicide, mental health or substance use crisis, or really any other type of emotional distress. I won't go through each one of these, but one of our Lifeline centers shared this with us just to kind of demonstrate the call subjects that people talk about when they are reaching out to the Lifeline. So it ranges from everything from suicide to anxiety, depression, to COVID, to relationships, and everything in between. So there's a variety of reasons why people call. It isn't just for people who are thinking about suicide. I do want to share a little bit about what the Lifeline is not. So it's not a peer support line. Minnesota does have 2 warm lines that are staffed by peers who could kind of fill that role of peer support, but 988 is not that peer support line. It's also not a space to solicit advice. The crisis counselors are there to help support the person, listen to them, and help safety plan with them. But they're not there to take place of any of that mental health, like therapy work. It's also not a place to have a mental health or physical health condition diagnosed, and it's also not a response service. So 988 does not respond in person to if someone is wanting a response. So if a person contacts 988 and is in need of some type of in-person response, 988 can facilitate the transfer of a call to the most appropriate resource. And it's most likely going to be either a mobile crisis team or 911 if it's an emergency response that is needed. And so 988 is not meant to replace any current crisis service out there. It's really meant to just enhance what's already there and try to get folks connected to local resources. So kind of what happens when you call 988, every person who calls 988 is first screened for suicidal risk. The 988 Suicide and Crisis Lifeline does have their own clinical standards and practices for screening for suicidal risk. And so this is just a model that they use. Calls don't always happen in this order. Um, but one of the things that they initially do is screen for that suicidal risk. And depending on the degree of risk that a person is, will really determine the nature of a call. So if someone is at imminent risk of suicide, that might look very different than someone who has a lower risk of suicide. But what each crisis counselor tries to do with each person that calls is actively um, have them participate in safety planning. So identifying coping strategies, identifying if there are friends or family that they can connect with, um, and providing them with local resources to the community if they need kind of that extra information and referral. So I do want to talk a little bit about 988, our Lifeline centers working together with mobile crisis. So there are mobile crisis teams in Minnesota. They are supported through the Minnesota Department of Human Services. I believe there are 32 mobile crisis teams, and they cover all 87 counties. Um, so just depending on the county that you live in, a mobile crisis team covers anywhere between 1 to 10 county. So just kind of depends on the region of the state that you're in. What 988 tries to do is de-escalate crisis calls as much as possible over the phone and really transferring calls to mobile crisis um, if if it's if it rises to the level of needing that in-person response. So some of the things that um, 988 is taking into consideration when they're thinking about um, transferring a call to mobile crisis is they're assessing the imminent risk of a person. So if a person has already attempted suicide and needs medical emergency, that's not going to be a call that they're going to transfer to mobile crisis. The other thing that they're thinking about is the consent to care. So a person does need to consent to working with mobile crisis before 988 can transfer them to mobile crisis. And then other medical concerns, whether the person is under the influence, may impact whether or not 988 does make that, does facilitate that handoff to a mobile crisis team. Some of the other things that our Lifeline centers are able to do is provide that information and referral. So all of our Lifeline centers, utilize the 211 database that is operated through the United Ways in the state. What they're able to do is provide information like phone numbers, addresses, services offered to people who call. One of the other things that we get questions on a lot is, do we collect demographic information? And the crisis counselors typically would ask for demographics if it's disclosed by the individual who's calling, or and really the purpose of that is to help provide the most appropriate resource for them. So if someone identifies as being part of a wanting tribal resources, our Lifeline centers could provide that specific tribal resource for that person. Or if that person is looking for a specific LGBTQ service, that would be information that the crisis counselor would collect, but they don't collect demographic information in order to receive service from 988. The other thing that our Lifeline centers also do offer are what we call follow-up calls. So it's a call that you would receive anywhere between 24 to 72 hours after your first contact, just to kind of check in to see how things are going, to see if there's any additional resources that are needed, if there's any adjustments to a safety plan. So after a person calls 988, before they hang up, the crisis counselor may ask them if they would like to if they would like to receive a follow-up call. And the person has the ability to consent whether or not they want to have that follow-up call, and then they would work with the counselor to identify the best time and the best phone number to reach them, and then they will receive that call 24 to 72 hours afterwards. So kind of what we're encouraging, what you can do, you can begin engaging with local partners to discuss how your community might use 988. If you have resources that you aren't sure if it's in the 211 database, you can always reach out to us, and we can always make those connections to ensure that if someone is looking for a certain type of resource, that we have that available, and can share that out with them. One of the things that we're also doing at MDH is we're also recommending that everyone begin phasing out the 1-800-273-8255 number from existing promotional materials. Um, of course, like I said, this number will still be operational indefinitely, so people can absolutely still call this number. Just what we're trying to do is that moving forward, have 988 be the public phone number that gets promoted. So if you have the 1-800 number on websites or digital materials, please go ahead and change that over to 988. If you have printed materials, please feel free to continue handing out materials with the 1-800 number on there. But if you're at the end of your pile and you need to make another order, um, go ahead and change that over to 988 before you print new materials. I do have the link on here, and I think the slides will be available to you, but it's just a link to the SAMHSA's webpage that has all the new logos for 988 and the branding guidelines that your organization can follow to get those materials updated. Next, what I just wanted to kind of just share and kind of end the presentation with is that 988 is really meant to just be that first step in transforming and reimagining what crisis care looks like. And so we know it's going to take many, many years and a collaborative effort on a lot of organizations in different sectors coming together um, in order to build 988 and the crisis care system into what we hope it will be. So we're really excited. We know this is just kind of the beginning. But we're really looking forward to continuing to partner with folks across the states and making access to crisis care more accessible for anyone who is needing that care. I've also, excuse me, what I've also included are some resources that folks can take a look at. MDH does have some crisis resources. It's called You Matter that you can use. There's also a lot of information from SAMHSA regarding social media shareables and things that you can post on your website around 988 and the Lifeline as well. So with that, I'm happy to take any questions if there are any. My email is here. If you guys have any questions about 988, you're welcome to email them directly to me. You can also email them to Mary and Caroline, and they can get those questions over to me as well.
Thank you so much, Emily. Anybody have any questions for Emily on this 988 presentation?
As we give folks a chance to type in their questions into the chat, I'm curious, Emily, is there any plan to make that crisis text or the chat available in different languages at some point in the future?
I don't know if there are any plans at the moment to make it available. But I think that that's something that a lot of folks have been asking for and are looking to. But the Lifeline right now is just encouraging that if people do need that interpretation service, to call 988 instead of texting and chatting.
Great, thank you, Emily. And I'm just seeing some thanks in the chat. One person is going to contact you directly. So I think unless there's anything else, again, thank you so much, Emily, for joining us this morning, and we really appreciate your presentation.
Thank you.
Great, thank you. So next, I'm going to turn things over to Mary Hopkins, and she and I are going to talk about some new resources for healthcare providers.
And Caroline, can you make me presenter?
Okay, hold on a second.
So I can share our slides.
I think that might have worked.
Yes, that should work. So give me just one moment and I will pull up our slides here. Well, as those slides load, good morning, everyone. My name is Mary Hopkins. I'm the Sexual Violence Prevention Program Director for the Minnesota Department of Health. I'm often behind the screens during these meetings, helping with some of the tech as we're running these task force meetings, but I'm really excited to share about a new initiative that we have. We actually have a couple of different new initiatives that we've been rolling out to train healthcare providers and really provide some support to healthcare providers and lots of other folks in the health fields so that they can better respond and prevent human trafficking and exploitation. So I'm going to tell you a little bit about one of those initiatives today. And as I discuss this, I'm curious, and I invite all of you to type into the chat, just think with me for a second. How many of you have, or maybe you know someone, who has ever left something out of a medical history or intentionally misreported information to a healthcare provider? Anyone willing to admit that maybe they've left something off of their medical history? Yes to that. I'm seeing a lot of yeses in the chat. And there are a whole lot of reasons why folks might not report everything to their healthcare provider. I'm already seeing someone in the chat saying potential stigma if they admit to something. They might have shame or fear. And in particular, when we think about communities and individuals who may have had bad experiences with health providers, Maybe they've been systems involved. Maybe they've experienced racism with their health provider in the past. There's a whole lot of really good reasons why people might not be sharing all of their information with a healthcare provider. And then when we think about how we've been traditionally screening around intimate partner violence or human trafficking, we can see why we're not really catching folks who are going to health providers who are experiencing these issues. So here's some real life experiences that we know folks have had going to the doctor. So we can imagine maybe their partner is seated next to the patient and the provider is saying, so no one's hurting you at home, right? Maybe the nurse is typing on the computer with their back to you and they're saying, so within the last year, has your partner ever hurt you or hit you? Or let's say they have a screening tool in hand and the way they present it is that I'm really sorry, I have to even ask you these questions, but it's a requirement in our clinic. Do you think that these providers know that the way they're asking the question is they're really asking for a no, right? They're telling the patient in front of them that they're not prepared to manage a positive disclosure. They don't really want to know, and they don't really want to deal with it. The ways that these topics are brought up with a provider really do matter and can provide a huge difference in how folks are interacting with their health providers. So we are proposing a new way to approach these conversations. So we are providing some training and doing some work using the CUES approach. And really, the whole purpose of CUES is to provide an alternative to traditional screening. And so when we think about CUES, disclosure is not the goal. You know, we're not trying to just see if someone says yes or no. It's not about checking off a box. It's about starting a conversation. And when we approach this as an open-ended conversation, it becomes also a conversation around prevention. When we recognize that all of us can be part of preventing human trafficking and exploitation, that conversation looks a lot different. It also means that everyone who is having these conversations with their health providers will have access to information on services. So it's not just someone who discloses to their provider who's going to get a hotline number or learn who their regional navigator is. It means that everyone gets this information. And in that way, we're also empowering individuals that even if I might not need this information, I might have a friend or family member who really could use some support. And now I have this information to share with others. We're also really encouraging and asking health providers to see victim advocates as part of the healthcare team. So we're not just looking at someone's health as this standalone part of their life. We're really recognizing that our relationships, our experiences, and potentially the violence or abuse or exploitation that this person is experiencing is a key part of their health. And so we need to be able to recognize and support them in all of these aspects of their life. So what is CUES? This is an intervention that was created by Futures Without Violence, and it stands for Confidentiality, Universal Education and Empowerment, and Support. So the training really walks health providers through these 3 steps. And the goal is that, you know, health providers are not the experts, and they really shouldn't be the experts on intimate partner violence or human trafficking. We've got a lot of experts here in the meeting with us today who can provide that support. What we're asking health providers to do is to really be able to start the conversation, ask these open-ended questions, and be able to respond and connect with the right people in their community to get access to services and support if someone is experiencing human trafficking or exploitation. And this intervention is really is using these safety cards. So you can see an image of some of the safety cards on the slide right here. We are providing these safety cards to health providers across the state so that they can support health providers as they have these conversations. So again, a health provider doesn't have to know everything. They just have to have this stack of safety cards sitting in their office so that they can walk through the safety card, asking the right questions and providing the resources and support to everyone. So the Minnesota Department of Health recently received some new funding to use this intervention. This is part of the Office on Women's Health grants to reduce maternal deaths due to violence. So we're really focusing on individuals who are pregnant and 1 year postpartum. And there's 3 pieces to this work that we're doing that we're really excited to get to work on. First is expanding some of our programs that review, identify, and track maternal deaths due to violence. So we're going to be able to look at the data that we have here in Minnesota and really think about what is the data telling us and how can we better use that data to prevent maternal deaths due to violence. We'll also be implementing this evidence-based cues intervention to improve outcomes and reduce maternal deaths due to violence. So we are reaching out to health providers, particularly those providers who are providing prenatal care, as well as other non-traditional providers. So we are reaching out to doulas, reaching out to other folks who might be in a place to intervene if someone is in an unhealthy or an exploitative relationship. And then we're also developing some sustainability plans to ensure that we can maintain this improvement beyond the life of the grant. So we've been doing this work for many years now with some key partners in Minnesota, Violence Free Minnesota, the Minnesota Association of Community Health Centers, and one of our newer partners is now the Minnesota Perinatal Quality Collaborative. So that's just a bit about the work that we're doing here to train health providers on this cues approach. We think this is a really promising way to get access to services to more folks across the state. And we invite all of you to reach out if this is something that you'd like to be involved in. If you know health providers who might be interested in getting involved, I'd love to know and reach out to them and see how we can get them involved in this process. So I'm going to hand it over to Caroline about our second initiative to train healthcare providers. This cues approach really provides a baseline, a really easy way for folks to start the conversation. And I think this next initiative that we have lets folks go a little bit deeper to learn a bit more about the issues.
Great, thank you, Mary. And will you be okay with just moving the slides for me as we go through? Okay, thanks. All right, so yes, the cues project is something that we have been talking about over the past few years at MDH, and it actually does provide a really important basis for the Safe Harbor healthcare worker training that has been put in place. And this is something that we actually started planning before the pandemic, and then of course the pandemic started and this got a little bit delayed. But we are really pleased that we've been able to roll this out over the past few months and now have this particular training available for healthcare workers in a variety of different settings. The point of this healthcare training is that it is short and it's easily accessible. It provides a lot of really important and timely information for working with patients who may be victims of human trafficking, either sex or labor. But we want to also make sure that it's a very accessible training for healthcare providers who are extremely busy and might be kind of trying to fit in information where they can. So these 6 short modules are no longer than 15 minutes long. All of this is available through the Minnesota Department of Health e-learning center, and I will provide the information about how to access it and then put it into the chat box too. As I mentioned, this is created for healthcare workers in a variety of settings. We really were focusing on emergency departments, but also community-based clinics, school nurses and counselors can benefit from this training, mental health providers, substance use providers, and other folks who are working in healthcare settings, I think would all find benefit from this particular training. Next slide, please. These are just the module topics that we have put together. The first is an overview and dynamics of trafficking and exploitation overall. Then we provide indicators of trafficking and exploitation. And a really big piece of this is the actual assessment of survivors of trafficking. And Mary already hit on some really important points out of the CUES program that are also really key to how we do an assessment and actually respond to the needs of patients who may be victims of human trafficking. And that does include not making disclosure a goal, meeting people where they are at when they are coming in to receive services, engaging with them, not turning their back, but actually facing them and being there as part of the provision of services and being very present, making sure that anybody who has accompanied them is not present so that the person is able to have a one-on-one conversation with the healthcare provider. And a number of other factors like that are covered in these modules. We do provide a coaching companion within this particular training. And as you'll see on one of the upcoming slides, we had a number of healthcare providers who gave us input in putting together this training. And so we have a lot of their best practices and tips included in this particular module. We also have services, resources, and considerations. This is a Minnesota-specific training, although certainly anybody can use it from anywhere around the country or beyond. But we do focus quite a bit on the safe harbor response in the state and other resources that we have available. And then finally, we talk about something called the ICD-10 CM coding. And what that means is in hospital settings, there is coding that occurs that basically identifies the type of complaint that somebody has come into the hospital for. It's one way that actually the hospitals are able to coordinate the visit and the billing. And so there is an extensive array of codes. And in the recent years, there were some codes added that have to do with human trafficking, both with adults and with youth and children. And so part of this training also explains the particular codes that are associated with human trafficking. And then just overall, we have a ton of resources provided within the modules as well. A big resource that they are connected to is Heal Trafficking, which is a national training resource for healthcare providers. They have a ton of wonderful material on their website. So if somebody wants to go further, they can look at that. There are also a number of tools that have been created across the country for healthcare providers, and we connect people to those as well. So we can go on to the next slide. This is the advisory group that we worked with. As you can see, we had some subject matter experts. We had representation from child advocacy centers, from Indian Health Services, from some community-based clinics, and also from major hospitals like Mayo Clinic. And then we also have worked with the Minnesota Hospital Association, and they have been really wonderful in helping us get this information out to workers who are doing this throughout the state and hopefully can access this training. We also worked with Dr. Jordan Greenbaum. She is a national expert on the response to trafficking and exploitation of children. She's been affiliated with Children's Healthcare of Atlanta, is also a leader in the HEAL response. And we were very fortunate to have her advising us on this project. And we had a consultant named Leah Lutz who helped to lead the groups where all the material was created and then put it all together for us so we could actually get it onto an online training. Next slide. This is the information about how to access the training. I will put the link into the chat as well. All you need to do is go to this portal for the MDH e-learning center. Just search for the human trafficking training. It's free. People can take it and apply for CEU credits. And we also have a link on our website where people can access more information about this. Next slide. And this is just our contact information for Mary and I. If you have any questions at all about the healthcare response, we really want to hear your feedback about these training materials. And as we move forward in our grant projects too, the actual healthcare training for trafficking does include an evaluation. So we will be paying close attention to that to see how people are receiving the training. And with that, that's our presentation, but I wanted to check and see if anybody has any questions for Mary and I.
I
Okay, getting some thank yous. Anything else? All right. Well, I will add the information into the chat. And with that, I'm going to thank Mary for co-presenting on this and for all the work that the Sexual Violence Prevention Unit is doing too. And now going to invite Juliet Rudie from the Office of Missing and Murdered Indigenous Relatives to provide us an update.
Morning, everybody. Thank you for inviting me to your meeting. I'm Juliet Rudie. I'm the director of the Missing and Murdered Indigenous Relatives Office. I started this position February 28th of 2022. So this year I've been in the office for about 8 months. I'm a tribal member of the Lower Sioux Indian community. And my background is in law enforcement. I spent 28 years in law enforcement until I retired in 2017. I began as a patrol officer with the St. Paul Police Department in 1990. And I was promoted to sergeant, then inspector, and then the director of training. In 2011, after 21 years with the St. Paul Police Department, I went to the Ramsey County Sheriff's Office and worked as an inspector and then the undersheriff of administration, and then also retired as the chief deputy with the Ramsey County Sheriff's Office. So in 2017, I retired, and if I said I would not come out of retirement unless it would be specifically to work for Native women and children. And so when the position for the Missing and Murdered Indigenous Relatives Office came up, I was like, this is an opportunity for me to make a difference and do more for the Native community. Native people in Minnesota and across the nation have been disproportionately impacted by violence. In 2019, the Missing and Murdered Indigenous Women's Task Force, MMIW, was created through a unanimous bipartisan support from the Minnesota legislature and was coordinated by the Department of Public Safety. The MMIR office falls under the Department of Public Safety Office of Justice Programs. Their objective, the MMIW task force objective, were to examine systemic causes behind the violence, examine appropriate methods of tracking and collecting data, report on policies and institutions, report on measures necessary to address and reduce violence against Indigenous women and girls, and examine measures to help victims, families, and communities. The task force included members of the 11 tribal nations, the Senate, the House, law enforcement, the U.S. Attorney's Office, the courts, and Native advocacy groups. On behalf of the task force, Wilder Research conducted extensive research for the project. And Wilder Research found that the root causes of MMIR were colonialism, historical trauma, racism, and the sexual objectification of Native women and children. Native women make up 1% of the population in the state of Minnesota, and they account for 9% of the homicide rate. They are 7 times more likely to be murdered than white women. Research found that from 27 to 54 American Indian women and girls in Minnesota were missing in any given month from 2012 to 2020. The numbers are similar for 2021 and 2022. The MMIW task force submitted their report to the legislature November of 2020, which included 20 proposed mandates necessary to address and solve the MMIR injustice. And the first mandate was to create the Missing and Murdered Indigenous Relatives Office. It started out as MMIW, and as it went through legislation, the name changed to Missing and Murdered Indigenous Relatives to include and be more inclusive of two-spirited people, and then also men and young men as well. Legislation to establish the office was signed into law by Governor Tim Walz in 2021. This issue permeates more than the criminal justice system, touching on a variety of systems that interact with victims, survivors, and their families. Large themes of accountability, uniformity, and accessibility have been coming up through our work as we have been identifying the critical issues that feed the MMIR crisis. Currently, the MMIR office supports and provides resources for impacted families and communities. We do case reviews, training and education in collaboration with 11 tribal nations and numerous community organizations, local and state agencies, and federal government offices. Currently, I'm working on hiring 3 staff for the MMIR office. Those positions were posted in August, and now the applications are in, the application process is closed. And the 3 positions are MMRI Violence Prevention Coordinator, and this position will develop, implement, and coordinate culturally responsive MMIR prevention and awareness program based on best practices and data-driven research. The second position is the MMIR Community Planner. This person will develop and implement comprehensive long and short-term range plans, projects, and programs for the MMIR office, and develop recommendations on administrative policies and procedures or services in response to MMIR. The third position is the MMIR Intelligence Specialist. This person will collaborate with Minnesota's tribal nations, bands, and communities, federal, state, and local law enforcement, federal and state agencies, and assist in investigating and establishing authenticity of data and collect and analyze crime data. I'm also working on a project to facilitate additional research that will support the development of an MMIR protocol that will include policies and procedures on reporting, response, and victim services. So that's what the MMIR office is doing currently in a nutshell. So I appreciate being invited to present to the task force. I'm impressed with the work that that's being done with human trafficking and with all that Safe Harbor does, and I appreciate being here. And so if anybody has any questions, I'd be happy to answer, or if you want to get in touch with me, please you can email me and I can answer any questions that you might have. So thank you for inviting me.
Thank you so much. Any questions for Juliet?
I just wanted to say thank you, Julie, for coming today. It's been great to work with you just as it pertains to trafficking. Julie and I have both recognized the correlation between trafficking, anti-human trafficking work, and the MMIR epidemic, and she's just been awesome to present. We've gone to a few different places and presented, so I just really appreciate your work and dedication, and look forward to connecting with you again soon.
That's awesome. It's really great to
I enjoy working with you too. Like you said, our work intersects, and you know, it's good to have your support, and we've done a couple of presentations together, so it's been good. It's been good to work with you.
There's a question here, Julie. It says, recently I've been watching Alaska Daily, wondering if this is a good awareness tool. Is it an accurate depiction of challenges in the MMIR work? Are you familiar with Alaska Daily?
People have sent me they text me, oh, have you seen Alaska Daily? And I'm like, no, I have no idea. Well, I know I've heard that it's about MMIR, but I haven't had a chance to look at it. I don't watch a lot of TV, so I do plan it to put on my winter list. If it's bringing awareness to the issue, I think it could be helpful, but sometimes the media or like TV shows might not have all the accurate description of what the problem is, because I know that being in law enforcement and watching shows about police officers and things like that, sometimes you just kind of go, oh, that's not really how it happens, or that's so I would have to watch it to see what it's about before I could comment on whether or not it's helpful.
I think some of
Yeah,
the issues that are in there talk about the jurisdictional issues, and I know that that's a big issue just as it's addressed. I mean, it's the same with trafficking. There's jurisdictional issues. Again, kind of the objectification, as Julie mentioned, of Indigenous women, and just how vast Alaska is, makes it difficult to get responses when crisis happens. So I think those parts, as far as I know, are accurate representation. I've seen other presentations that kind of speak to that. So there are some real life issues that come out in that show. I don't know that you should, take it with a grain of salt, I guess I would say, but that's what I've heard anyhow.
Great question. I have been recording it. I haven't started watching it yet, so I'm really interested to see it. We have another question here. Thank you for your service, Julie. What was the number of cases that you said occurred between 2012 and 2020?
It's from 27 to 54 American Indian women and girls in Minnesota were missing in any given month from 2012 to 2022. I get a monthly report from the BCA, and it's a generally about the same, and I feel like it's underreported, but that's something that the MMIR office is working on, because the data, there is no real-time data on missing persons. And so, and to me, that's a problem, because it's like, how do we know where to deploy resources, and how do we know how to effectively help with the issue if we don't have accurate data? So that's one of the things that is in the mandates. The 20 mandates is to work on data collection and then streamlining the data. I get a lot of emails from tribal nations, from the community, on missing persons, missing Native women in particular, and men as well. And I check in with the BCA to make sure that the information is entered into NCIC, because sometimes it isn't. And then if it can get into NCIC, then we can get it into the Crime Alert Network, which is helpful, so that it gets out to other law enforcement agencies. But it's a problem. The data collection is a problem, and the real-time stuff is a problem. I'm just shocked that not enough attention has been given to missing persons overall. I mean, when I was in the police department in the 1990s and early 2000s, I worked in the missing persons unit, and it was very how do I want to put it? I mean, very minimal amount was done. You get the missing persons report, and then you'd follow up with the family on where they were at, but there were never really any active investigations like now. I mean, they're doing much better tracking people down through their cell phone data, our social media. So it's gotten a little bit better, but as far as is our native population, with the statistics like they are, we need to do more. I mean, we have to get out there and actively look, and to help solve the problem. And part of that is getting accurate data. And then, you know, in the protocol, I think is going to be very helpful on reporting and response, and then victim services to help the family.
Yeah, thank you,
If
Julie.
I could jump into that too, Julie, I mean, was on social media this weekend, and there's a lot of stigma. Like there's a couple young women in the Twin Cities who are missing right now. And in kind of interacting with those families, they're afraid to report to law enforcement because the mistrust, they're afraid to get, like, you know, child protection involved if it's a mom who has, you know, mom who's missing, but also like they're just afraid. This the two cases that I was kind of looped into over the weekend where it had to do with folks that were dealing with chemical addiction, which is a symptom of a lot of different things, but just that, you know, kind of that it's hard to know when to report somebody who's struggling with addiction as missing, because they have a tendency, some folks have a tendency to just kind of lose contact with family. And so these families in particular were struggling. So that real-time data that you're talking about, it could be, you know, it's super underreported and families hesitate to report, I think is another issue.
Thank you, Anna. Another question, when is the 4th position being posted?
Okay, there is, I'm looking, I asked for in the budget. We'll see how that goes for next year. I would like to hire a victim service or victim specialist, because I'm finding that in this work, I'm working a lot with advocates, and the advocates have been amazing, being the go-betweens between law enforcement and the family. So a victim specialist, hopefully next year, and then also a case review coordinator position where this person would work on cases where they're like a person that was murdered, it was deemed overdose or a suicide, and the family feels like everything wasn't done like it could have been done or should have been done. And so I've been I've done a few case reviews where I work with the family and the law enforcement agency. And luckily, the BCA has been very helpful in looking at cases where it was deemed a suicide or an overdose. And then we go through the case and see if everything was done that could have been done, and then go through that case with the family. So a case review coordinator also hopefully for next year. So it would be 2 positions. If it doesn't get approved, we'll just keep going. I'll just keep going at it to hopefully hire some more staff.
That's fantastic. You have done an amazing job building this office from the ground up, and getting it up and running. And we so appreciate working with you. And I think, let's see, just looking here at the chat, Anna brought up the points about the family connection, and Fran Kingbird is mentioning that there's continued struggles getting help from the local police department for a case. And I guess really that's a good question, Julie, is how will you be continuing to work with local police departments to raise awareness and have them partner more on these cases?
So with this new protocol that we're going to develop, it will be pushed out through the tribal nations, but also law enforcement. My goal is to have that training be a part of the Minnesota Peace Officers and Standards training, and that it be included as a learning objective for when people go into law enforcement. They have to take the training for the MMIR protocol. And then also the training, the BCA has offered to push the training out through the Bureau of Criminal Apprehension has offered to push the training out as well. But this will be best practices that from the state and at a national level, and the goal is to push it out to all law enforcement, county, county, state, and local law enforcement. So that's the goal. And I'm pretty persistent. So I know that having that career in law enforcement, I know where to go and what to do to help push this through. So, I mean, fingers crossed. I hope it all goes okay, but I know it's not going to be easy. But I equate it to the domestic abuse protocol that was implemented in the 90s, and Duluth, Minnesota started it, this trend, and it became a national trend on how we respond to domestic violence. And that's my hope with the MMIR protocol, that it will be an example here in the state of Minnesota at a national level.
Yeah, absolutely. And I think that's a great thing to compare it to is, it just takes a while for that awareness to grow. And now, now that is something that's very well known with domestic abuse. And after that, a lot of work was done on sexual assault too. And now this is kind of a whole other level. So thank you for your efforts to get that implemented. If there's anything we can do to help and support you, please let us know.
It's very personal to me, this problem too. I mean, I have a cousin that's been missing since 2017. I've had 2 cousins that have died in violent situations where the perpetrator wasn't found. So it's very important work. And it's very important work. It's got to be a holistic approach, and then also within our own community too. So that's why it's very important to collaborate with the 11 tribal nations. And I have been out visiting with them. I haven't gotten to all of them yet, but I will. We're scheduling consultations with Commissioner Harrington. So we will be out visiting them and getting their feedback on how they can help. And also I'm letting them know about the MMIR protocol, and that I'll be looking for their feedback on how we can move forward with that work.
That's great, Julian. And I'm so sorry for the losses and personal experiences that you've had with this. And I think that also really points to how close to home it is for so many people, and why it's so important to have this office in place in the state. So thank you so much. I just want to double check and see if there are any final comments or questions for Julie. Great. Thank you again, Julie, for joining us. It's really great to see you. We appreciate everything you're doing.
Thank you. Thanks for having me.
Absolutely. Right. So I am just going to do a quick wrap up on safe harbor work with a few updates before we end for the day. Actually, it's a good segue from Julie to my first announcement, which is that Minnesota has received its 3rd Office for Victims of Crime grant, which is the Improving Outcomes grant for child victims of human trafficking. And we are really excited to have this for the 3rd time in the state. It's $1.5 million coming in from the federal government. And this work is crucial to us continuing our partnerships with the tribal nations. There is also some funding within this grant that will be going towards Julie's office, MMIR office, DPS, in order to support their work. Another piece of this grant will support embedding a victim advocate at the Human Trafficking Investigators Task Force at the BCA, and will allow us to build up our partnerships with urban-based Native serving organizations in Duluth and the Twin Cities area. So we are really thrilled to be able to have this grant again. Amanda Colgrove on our Safe Harbor team at MDH manages this grant. and has done an amazing job doing so. So we are really raring to go to get up and running on that effort. And the other piece I want to say about that is it also helps us to continue our partnerships with survivor-led and survivor-focused organizations so we can have more engagement by survivor subject matter experts. So that includes the Eniton story and also Pride at Family Partnership. So with that, we will be getting going on that grant very soon. I also wanted to let you know that we will be formally announcing soon an exciting new grant partnership that MDH has with the University of New Hampshire, as well as the University of Minnesota. It's a grant that's through the Centers for Disease Control, which will be looking at implementation of the Not a Number prevention curriculum in Minnesota. We'll be sending out a lot more information on that as we get to a formal place to talk about that grant. But just wanted to let you know that that is happening. It's going to be occurring in the state over the next 5 years. Question here, can you repeat about how the grant will be used in Duluth? Yes, we will be partnering with American Indian Community Housing Organization in Duluth on that particular grant. Okay, the other thing I wanted to let you know is that we do have some updated handouts on Safe Harbor on our website. We have our sort of general program handout, and that is available. It does have some updates on there. And so if you have old versions of that, please go online and download this newer version. And as always, we are continuously updating our services map as well, and that is available on our Safe Harbor page. The other thing I wanted to plant a seed about is that MDH and DHS we're both going to be starting our request for proposals process in the next few months. And these are for our grants for regional navigators, supportive services, and shelters, housing, and outreach in the Safe Harbor program. And you will be seeing a lot more about this coming up, but we expect that the request for proposals from both agencies will be going out in mid to late winter. We are going to stagger them so that you're not stuck doing 2 big state grants at the same time for those of you who will be applying. And there will be a lot more information coming about what the application process looks like. The other piece I wanted to let you know about is that through our partnership with Mille Lacs and also Heather Collier, a consultant who works with the Safe Harbor program quite a bit, and several subject matter experts, we have put together several survivor support materials, and these include sample contracts and invoices and other guidance for survivors who are seeking opportunities to work as survivor subject matter experts in the field. And it also includes guidance to people who might be hiring and working with survivor subject matter experts. It's an excellent package of tools that's been put together. We are working to get a link for that up on our website, a connected link. So we did send it out on the MnSTIP listserv about a week and a half ago, I believe, or 2 weeks ago. However, we can certainly send those documents to you again if you're interested. And again, they will be up on a website soon where we can send you a link about that. And then I also wanted to mention that the Minnesota Coalition Against Sexual Assault has put together a great resource for developing protocol in relation to the Safe Harbor response. There are the Safe Harbor protocol guidelines that are over at MNCASA's website, and along that you will see this new guide, which helps to take those protocol guidelines actually to the application and work in the field. So I definitely suggest taking a look at those materials too. And I'm going to drop a link here into the chat so you can find those. And so with that, those are all my updates from Safe Harbor. But if you have any other questions, got a few extra minutes here, so I'm happy to answer anything that you might be interested in.
Yeah, Caroline, we did get a couple of questions come in through the Q&A pod. Maybe we can start with, I know we often have some new folks joining us at these meetings. Can you provide just a quick summary of what Safe Harbor does?
Sure, absolutely. So Safe Harbor is Minnesota's statewide response to human trafficking with a focus on youth who are through age 24. So Safe Harbor actually began back in 2011 when a law was passed in the state, which recognized that any youth under the age of 18 should not be criminalized as a victim of sexual exploitation, that they are in need of services and support. After 2011, there was a 3-year planning period called No Wrong Door to build up a system response in the state so that our various state agencies, nonprofit partners, other partners across the state were prepared to serve youth through a No Wrong Door. So no matter where they went through the system or on the community level, that they would find somebody who was aware of what trafficking and exploitation of youth looks like and would be able to offer them services and support. So in 2014, the Minnesota Department of Health created the Safe Harbor program. This is, again, all through legislative support. And the director was placed at the Minnesota Department of Health because we really wanted to emphasize a public health approach to trafficking and exploitation in our state. So there was a prior director to me. Her name was Lauren Ryan, and then I followed up and started in this role in 2018. Over the years, the program has really developed and grown. While the work is centered at the Department of Public Health, we partner extensively with the Department of Human Services, as you saw with Anna here today, and we partner also with the Child Welfare Response and the Vulnerable Adult Response that's based at DHS. We also partner extensively with the Department of Public Safety, including the BCA, and that will include our work with Julie, with the Human Trafficking Investigators Task Force, and other aspects of the human trafficking response over at DPS. We also partner extensively with 9 out of the 11 tribal nations in the state through state funding and also federal funding, and that includes the Trust Task Force, which is the tribal response through law enforcement to sex trafficking. While Safe Harbor really started off with a focus on sex trafficking and exploitation, with our first federal grant a few years ago, we were able to expand and do more work in the area of labor trafficking and exploitation too, and that continues to be supported through our federal work. It's been really important to us to not silo all of the various issues around human trafficking because they overlap and impact each other in a variety of different ways. And so now today, here in 2022, with Safe Harbor, we have close to 40 different grants that we give out, and that is through MDH for regional navigators and supportive services, and then also through the Office for Economic Opportunity in the Department of Human Services, which manages all the shelter, housing, and outreach grants. We also, like I said, partner with 9 out of the 11 tribal nations. And we have a variety of programs going on. We provide trainings, we provide technical assistance. We do an evaluation of Safe Harbor as required every 2 years. So there's just a lot going on here on the state level, but I'm happy to provide any other information if you need it. But please definitely go take a look at our web pages. We can put them in the chat for you. It includes a wealth of information about our response in the state. Hope that was helpful.
Yeah, we got a follow-up question there about do we list legislative bills about trafficking on our website during the legislative session? And maybe where can folks go to find information on current legislation?
Sure. So we do not do that. As a state agency, we have a sort of unique relationship to the legislative process in terms of human trafficking. So we don't promote any legislation unless it's within the governor's budget. However, there are a number of advocates in the community who do work with the legislature. And so you can certainly reach out to them. There are people who are working on increasing funding. There are people through the Youth Services Network, which is based in the Twin Cities, but also has partners throughout the state. I can put some information in here about them if you want to reach out to them. They do a lot of advocacy during the legislative session. So while we don't list that, what you will sometimes hear during these presentations on the Human Trafficking Task Force is we will have people come in and talk about any legislative action that is happening, so you can get up to speed on that. I also see a question here about who is a good person to contact for a new survivor-led organization to get funding that might be available. Yeah, so right now, we don't have the request for proposals ready yet. We will definitely be posting those and getting them out. So keep an eye out for that, probably in late January. And at that time, you would be able to apply and certainly ask any questions too. Okay, I was wondering if there's a question here. I was wondering if there's any residential placements that would accept a female sexually exploited youth who has a criminal sex charge and awaiting a court hearing in November. Placement is being denied due to the crim sex charge. Thanks for any suggestions. That is a really tough situation. And I don't know, Darianne, I know you are on. I don't know if you can talk about this from the DHS perspective in terms of residential placements. Or Anna. I think what I
Any residential, but there is some outpatient programs that work specifically. If you want to reach out to me directly, that might be able to work with that person. So Jennifer, if you want to reach out to me directly, I have some suggestions for you.
Okay, great. Thank you. And I'm sorry, Darianne, I realize now you're muted because you're not a presenter. But yeah, Jennifer, I would definitely, Anna is a great place to start, and Darianne also over at Child Welfare. But I can definitely empathize that that's probably a very difficult situation to overcome. Okay, any other questions about Safe Harbor? Great. Well, thank you so much, everybody, for joining us today. It was a day of lots of updates and good information about what's going on around the field. So I really want to thank all of our presenters for joining us today and for sharing such important information. And thank you, all of you, for joining us and spending your time with us this morning. Please do not hesitate to reach out if you have any questions, if you have any case situations going on, or anything else that we can help you with. And I hope you have a good rest of the day.
Oh, and before folks,
Caroline,
Oh,
yeah,
the
I'm just
polling,
gonna
the
jump
polling,
in. Is it
yes.
okay before
Yes.
folks leave? We have a polling question for you, which is
Yes.
replacing our normal evaluation.
Yes.
So I'm gonna open a poll.
Yep, here we go. Please complete the poll before you go.
So we're just wondering a little information about how this meeting helped you today. If you could select all that apply from the response list here and submit. Thank you. So it looks like most folks have completed the poll and it's not in progress by anyone. So I'm just going to go ahead and close that. Thanks, everyone. Have a good day.